Okay, we're live. I see, as you guys can see in the participant list, people have been eagerly anticipating this one. They're going to file in real quick. For everyone hopping in, thank you so much for joining us tonight. We're looking forward to this topic with Dr. Gamble. We're very honored and blessed to have him working with us and joining us tonight. So this is going to be a really informative session. So welcome, Dr. Gamble. I'm going to call you Pat, just to be a little less formal, if that's all right with you.
Sounds good.
All right, great. So we're going to start promptly at 7:30. So we got 5 minutes to make sure everyone gets in here. I did send a message saying we'll be starting promptly. We do have a lot of information to get through tonight. A lot of interesting information. Thank you to all those that have sent questions ahead of time. Again, we're going to do our very, very best to answer as many questions as we can, time permitting. But we'll get through as much as we can tonight. I think we're going to be fine. For those as well who are popping in right now and are eagerly waiting, if you haven't done a Zoom webinar before, at the bottom you'll see a little chat button. If you hit the chat button, you'll be able to send a message. So you can drop the menu of all panelists to all panelists and attendees, so that everyone sees your question or comment, or just all panelists if you wanted to keep it private for just us to read. Okay, so that's simple there for everyone. But it's great. We're getting a lot of people streaming in right now, which is awesome. And it's a nice Wednesday evening. How's everyone doing? Giacomo, welcome. How are you?
Thanks. Doing well, Mike. Patrick, doing well. Sitting at home here, enjoying some time with the kids. So it wasn't too bad today. Wasn't too bad. It wasn't as hot as yesterday, so we were able to get outside. So
yeah.
Seeing the list of attendees growing here, seeing some familiar faces, or at least familiar names, rather.
So we've got some really exciting hot news off the press. The medical directives have changed for healthcare providers, and our clinics are ready to reopen come Monday. So we're super excited for that, and looking forward to getting patients back in and helping them out. So for those who are patients of ours, we're sending out an email tonight to let you know we are reopening, and we will be booking appointments starting next week. We've got lots of safety measures in place, new cleaning protocols, etc., to make it a nice, safe environment for everyone to feel comfortable and get the treatment they need. And I know, Pat, the hospitals will be probably getting some surgeries going soon, obviously, right?
Yeah, hopefully, Mike. We're anxiously awaiting the ORs to be reopened for scheduled time soon.
I'm sure you have a long list of patients who are eager to see you.
Yeah, there is.
Yeah, so well, that's good. I mean, obviously, this is good for everyone. I think we're moving on a little bit here, and hopefully it's safe and everyone gets through this together. So it's great. Just a few more minutes here before we get started. Again, welcome everyone who is just joining us. If you notice in the chat there, you can type in something here. So Art reads, can't see anyone. Not sure what's happening on your end, Art. Anyone else having any issues with their video or ability to see us? I think for the most part, everyone's doing okay. Yep. Yes, I see lots of messages coming in. Go ahead, Giacomo.
No, I was going to say, Art, you might want to try to enable your camera if that, or something, when you try to, not enable your camera rather, but go into some of your options on Zoom and see if that helps there in the video options.
If not, hopefully you can listen. Everyone can see us, so that's good. They can see us and hear us. That's awesome. So that's great. I think we're going to get started right away. It's 7:30. What you'll notice as we're speaking is you should be able to see the speaker as we're talking. And we'll get started. So why don't we get it going here? Welcome everyone. Latest trends in hip and knee osteoarthritis. And again, we're really pleased to have Dr. Gamble here with us tonight and sharing his expertise with us. So we really appreciate him joining us for this session tonight. So welcome, Pat, and let's get started. So moving on here, speaking tonight, my name's Mike Pomelli, for those that don't know me. I'm one of the clinic directors here at Aurora Sports Medicine, along with Giacomo. And Giacomo and I will be speaking a little bit tonight. And we'll be able to kind of guide some things along here, and hopefully Dr. Gamble will be able to provide plenty of insight on the surgical side of things. Okay, so let's move on. Dr. Gamble is a surgeon here with South Lake Regional. He's an orthopedic surgeon. And he's also our medical director here at Aurora Sports Medicine Professionals. So some of our objectives tonight, we're going to talk quickly about osteoarthritis, how it progresses over time, the latest medical trends, 3 ways you can manage this right now, some cutting-edge non-surgical treatment options, and the #1 tip that Dr. Gamble is going to give us. So let's start quickly with a poll. Okay, let's do a quick poll with everyone here first. So I'm going to put this poll up and see if everyone can answer this for us. Okay, so here comes the poll. It should be coming out any second now. And you should be getting it now. It's all popping up there, right, guys? You see that? Giacomo, you see the poll there?
Yeah, see some people coming through here. We got some bunch of people voting now.
Awesome.
There we go. All right. It's looking good. We only have somebody, one person less than 25. Oh, there we go. 2 people. A couple people that are younger than 25. All right.
You seeing these some of these results? They're coming in. They're coming in pretty good. You seeing some of these results here, Pat?
Yeah, I am, Mike.
Yeah, great. Look at that. There's a lot of knee arthritis out there. You can see that one. And look at that, guys. A little bit of exercise and therapy and medications. Those are the big ones right now that a lot of people are using. So that's great. And not many people have had a joint replacement. Some have, and a small percentage now need to have another one. So, all right, I think that's a good perspective here. I'm going to end the poll, and I'll share some results here quickly. And here come the results now. Everyone see those there? You guys got those?
Yeah, looking at him.
Okay, so age range. So we've got, a population that's in this osteoarthritis category for sure. And what joints affected? Well, there it is. The knee is the #1 that's most affected right now. A lot of people are doing exercise and or therapy. That's what they've tried in the past. And there's a whole variety, obviously, of things that people have been doing. And have you had a joint replacement? And a lot of people are no. So I'm just going to end that there. And let's get started. All right, let's moving on now. So Pat, if you want to take us through, why don't you explain a little bit about what osteoarthritis is and how it's been moving along here?
Thanks, Mike. Thanks for having me tonight. Thanks, Giacomo, as well, for both of your guys' hard work in the clinics and for setting up this evening. And special thanks to everyone out there who's tuned in. Appreciate you taking your time, and hopefully you'll come away from this hour with a little better understanding of osteoarthritis. Osteoarthritis, as probably most of us know, is a very common disorder, but in fact, it's actually the most prevalent chronic disease in Canada. And when you look at some of the statistics and the age demographics, you can see over half of the people that have it are actually under 65. In fact, when you looked at our poll today, I was just jotting down a few numbers today. Even on this webinar tonight, we have over 30% of people are in their 50s that have osteoarthritis. And you look at the next 20 years, Canadians are living longer. And in 2017, we had nearly 5 million Canadians suffering from arthritis. And that's going to expect to grow to nearly 8 million. So it's going to nearly double in 20 years. And when you look at the economic cost of osteoarthritis, it's also nearly going to double. It's going to go from $30 billion to nearly 70 billion. So this is a real problem for a lot of people in Canada. And it sounds like from the audience today, a lot of problems for those that are attending. So what is arthritis before we start talking about what arthritis isn't? Well, osteoarthritis, it's a degenerative disease of a synovial joint. So it involves degeneration of all parts of the joints, and in particular, that cartilage layer, which is like a shock absorber. I always use this analogy with my patients. It's like you're driving a truck on a dirt road, and when that truck's got great shock absorbers, you barely feel the ride. But as soon as those shock absorbers they stop working, then you feel every bump along the ride. And that's often what happens when people have progressive osteoarthritis. Their joint, that articular cartilage, which is like the shock absorber, isn't working. And then that force that's going through the joints as you ambulate gets distributed to the bone underneath the cartilage layer, and that bone is highly innervated and it hurts. So what is osteoarthritis not? Because there's lots of misconceptions about what it is. So it's only a disease that affects the elderly. Well, that's false. You can see even from the audience this evening, over 30% of the people are under 60. A lot of people come in, they say, I don't understand how I got this. I never injured my knee. But the reality is osteoarthritis, even though it's considered degenerative, it's a biologic process, and you don't need trauma to start that cartilage breakdown. I have a lot of people that come see me and they're like, well, doc, I got this MRI and it shows I have some meniscal pathology. But the reality is you don't need any advanced images to make the diagnosis of osteoarthritis. A good history, a good physical examination, and then some good radiographs are probably the most important things to make that diagnosis. And lastly, people often concerned that exercise, especially in the setting of moderate to advanced osteoarthritis, is going to cause further breakdown. And that can be furthest from the truth. In fact, you'll hear from us this evening the importance of exercise, the importance of strengthening those muscles around the joint to help reduce the pain and disability. So here's a picture of a knee joint. I'll just go through some of the anatomy here, and this is a little busy slide, but you can see here, this is a classic knee joint. You've got the femur bone, which is your thigh bone. You got your tibia here, which is your leg bone. At the end of each of these bones is depicted in blue is the articular cartilage, which is the shock absorber. And when you look at it grossly, it looks like a pale white structure, but underneath that structure is a complex biologic process. It's got big macromolecules, it's got some cells in it, and those cells secrete all sorts of different chemicals and hormones to keep that a nice healthy joint working well. The interesting thing about all synovial joints is that it's a contained space with this thick capsule. This thick capsule is important as we talk about various injections you can do to hip and knees and other synovial joints. And so the important thing to realize and to get out of today is that the old thought that osteoarthritis was just this simple wear and tear, this mechanical problem, is probably not true. It's definitely more of a biologic problem And we're understanding it more and more as more science helps us understand all the various biologic hormones that are used to regulate that joint. And that's important because if we can understand how things work, how disease becomes disease, then maybe we can fine tune our treatments for this problem. So it's always good to, when you're learning about something, is to look at some real life cases. So I got a couple cases this evening to show you. These are real people, real patients of mine. And we're going to start with the hip, and then we're going to move to the knee. So my first patient, he's a 52-year-old gentleman. He's a construction worker, and his past medical history is that of high blood pressure, so hypertension. The question I was asked people on the history is their activity level, how active they are or inactive they are. This guy's a classic 50-year-old guy. He's a weekend warrior. He works during the week. He works hard. He's got a labor job. Thursday nights, he enjoys a game of hockey and some beers after with his buddies. On the weekend, he tries to do some short runs. He was a runner when he was younger, but as he's gotten older, he's kind of let that regular running routine settle down, and so he only runs on the weekends. But he's been noticing progressive groin pain in his groin, which affects him when he's playing hockey, and running, and now even just some day-to-day activities. And this is a pretty typical story. In fact, usually it's one of my buddies when I play hockey, and it's like, hey, Pat, my groin's bugging me. And they think it's a groin strain. And, groin strains are common. And then a few months goes by, and the groin strain just doesn't seem to be improved. And then a few more months go by, and eventually they're like, can you check me out? And so I come in, I listen to them, take a history, do a physical examination, and then we get some plain radiographs. And as you can see in the slide here, this is a frontal view of a hip joint. And for those non-medical people in the audience tonight, you can see here, this is your femur bone, so your thigh bone. It's got a couple bumps sticking out of it. This is the greater trochanter. That's where your hip abductors attach onto. You've got your your lesser trochanter here, which is your iliopsoas, your hip flexor. That's what attaches onto that. And then you can see at the joint level is the hip joint's like a ball and socket joint. And I outlined the femoral head, which is the ball. And ideally it's nice and spherical, but you can see in this x-ray that the top portion where he's actually weight bearing is quite flattened down. And then on top of that, you can see this white line, and that's the socket, which is a part of the pelvis, often known as the acetabulum. And I'll point your eye to the cursor here, and you can see there's a bit of a gap on the inside part between the femoral head and the acetabulum. And what lives in that space is the articular cartilage. And the reason it's black on this x-ray is because articular cartilage does not have calcium. And when you shoot x-ray beams through a body or an extremity, what ends up happening is the beams get absorbed by the bone, and anything soft tissue or devoid of calcium, the beams go through and expose the film beneath the patient. And so what we're looking for in a nice healthy joint is a nice round spherical ball and lots of space between the ball and the socket. You can see it here, but then when you look to the top here, this patient, you can see there's no space. It's bone-on-bone arthritis. And so this patient's diagnosis, by the history, the physical, and x-ray, so no other specialized tests, is straightforward, severe hip osteoarthritis. What do we do? Well, as a surgeon, you kind of break things down simplistically. Is it something I can do with an operation? So surgical treatment options, and then non-surgical treatment options. Now, COVID-19, unfortunately, is taking a toll on all of us in lots of different parts of our lives. But, in my life, there's been 3 months where all my scheduled surgeries have been postponed. And unfortunately, this impacts a lot of people that were waiting for hip and knee replacements. And the future ramping up, which is going to begin soon, is going to be really slow, which means these wait times, which were already an issue prior to COVID-19, unfortunately going to get worse. So part of this evening tonight was a bit of an idea between Mike and Jack and myself, is how can we help people out there that either have early disease to keep them active for as long as they can, or those that have advanced disease that are waiting for their hip and knee replacement, and hopefully give them some relief up until that operation. Because at the end of the day, arthritis ain't going to kill you. And that's an important thing to understand, is what we're looking at tonight and what patients that have osteoarthritis are suffering from is pain that causes disability and affects their quality of life. So we always start with non-surgical options.
Yep.
Well, the first things we look at are, exercise. We obviously talk about activity modification, pharmaceuticals like Tylenol and anti-inflammatories. And I find a lot of patients that do come see me haven't tried those. And I would encourage anyone that's suffering osteoarthritis to consider regular routine use of Tylenol arthritis. It's an extended release Tylenol. It's very safe. It's metabolized through the liver, so it affects very little drugs. And you can even add in an anti-inflammatory, simple over-the-counter ibuprofen, Aleve. They get metabolized differently and they work well in combination. But after you've tried that, exercise is a great place to start. And we'll go into detail about why that is a little bit later, in addition to the physiotherapy, which is also important. But, up until probably about 6 months ago, that was really all I could offer people in terms of non-surgical management. And then I'd say, well, when this doesn't cut it and you impacting your daily life, well, then come chat to me about surgical options. But fortunately, now we've got some other new things that have presented themselves over the last few months. And that includes hip bracing and the ability now to inject a lot of the injectables we'll talk about later this evening into the hip joint. So I'm going to pass this over to Mike, and Mike's going to talk about custom hip bracing.
Yeah, so thanks, Pat. To your point, you're right. There hasn't been many options for bracing, and subsequently people were left with exercise, medications, and now there are new innovations coming out. One is by a company, Oster, that has the unloader hip, and you'll see this picture here on the right, which shows the depiction of the sleeve that's worn. It's almost like a bicycle short kind of material, and it's worn under your clothing. And basically what it does is it'll reduce the load on your joint surface. It helps to improve your treatment of your arthritis, whether you're exercising or staying active, reducing pain. And how does it work? Well, it will gently rotate the leg. I'm going to show you a quick sample here in a second. It kind of rotates the leg outwards a little bit and pulls it a bit away from the body, because in the picture that you saw that Dr. Gamble showed, that hip joint is starting to kind of come in on itself, almost like a bit of like a peppercorn mill. It's really sort of grinding its way in there. And the idea with these unloader braces now is to help derotate the ball in the pocket and help promote that movement, distracting it away a little bit. And it occurs dynamically. So it's the feature of these newer braces now is it puts the pressures onto the joint when you need it the most and relieves the pressure when you don't need it. So in certain positions, it will help the most. So I have a little sample here. I'm just going to pin my video here quickly to show everybody. Okay, so here we are. Here is the sample. Here's my wonderful mannequin. And how this will work is, in essence, you place this whole short compression sleeve on, okay? And you'll be using these straps to help connect it up in front, okay, like so. And this little dial here comes right through the leg and up and around. And as we dial it up, okay, you'll see that little device moving. It helps to turn the leg out. So as you're taking a step dynamically, it's going to help pull, open the hip up, and relieve the pressure that's going on inside the hip. So quite an innovative product. It is a little bit of a device to put on and use, but it's very streamlined and super light, and it does provide a ton of relief for people. And to Dr. Gamble's point, some of these younger individuals who are playing hockey, some hockey players put these on underneath. It's like a compression short. They can skate, and they don't get that pinching feel that you have in your hip, which I know a lot of people do experience. As a physio, that's what I listen to all the time. They talk about that deep hip pain radiates down the leg. So this is going to help unload that. Okay, so that's an option there. I'm just going to unpin my video here, and we'll get back to that presentation there. So you can go ahead there, Pat. That was just a quick talk about that unloader hip, okay?
Thanks, Mike. I'm just going to ask you a quick question. How comfortable are they to wear?
Actually, they're quite comfortable. I have put it on myself. Again, it's like a pair of bicycle shorts. It's non-invasive. When you have it on, it actually does, those straps that come around that I showed at front, they do compress around the hip, the low back, and it can really help to stabilize the low back and, you know, feel a little bit better. I see one of my friendly patients has asked me to put it on. That might take a bit of time. We don't need an epic fail out here in tonight's session. If you have both hips with an issue, actually there is an ability on this product to have the unloading feature built onto both sides. So you can have this dynamic strap on both sides of it, so you can unload both hips if you had to. So you know, it's comfortable to wear. There are sort of male and female versions of it to attribute for the difference in dimensions and body shape. So not as cumbersome as it looks. So Richard, I'll tell you a little bit about the bracing towards the end, but these are custom. We measure for you. We can do them here at the clinic. Typically, the custom braces will range in the $1,800 range as a custom product. So that's, you know, one of the perhaps drawbacks of some of the bracing options. But again, they are customized products made for you from these companies. So it's according to your fit, not just an off-the-shelf version. Okay. So.
That's great. Thanks, Mike. So, you know, again, we're talking about non-surgical treatment options for hip osteoarthritis. And we've looked at pharmacologics, so non-narcotic medications, some exercise, physio. Mike's just showed us some custom hip bracing. And then there's a whole slew of injectables, which really have not been available for patients that suffer hip arthritis. And part of the problem was, you know, the hip joint is not a superficial joint, unlike the knee, which means you need to know where you are and how to get down to it. And the only real way to do it up until recently would be a procedure in diagnostics. So you'd have to come to the hospital. They'd use x-ray guidance. They'd stick a needle into your hip joint under x-ray guidance, and then squirt a little contrast in there, which would be a dye to know that the needle's in the right spot. And they'd inject in one of the various injectables you could consider for the treatment of arthritis. And so, you know, it was often a procedure that may come with a cost to the patient. It was a little bit cumbersome. And these days, probably not a lot of people want to go into the hospital for something like that. So ultrasound has come a long way. In fact, now there's these handheld devices, and on the slide today, this is one of them. There's a few of them on the market. This is called the Butterfly IQ. It's new to Canada, and you can see it just connects to any real handheld device, and it gives you a quite detailed assessment of the soft tissue or bony anatomy. And so anyhow, I actually now have one in the
You have one here, right?
I do,
yeah.
I do, Mike. So actually just—
Do you want me to pin your video here?
Yeah, sure. That'd be good.
Okay.
So anyhow, this is it right here. You can see it's a handheld device. And what we do is you just plug it into your iPhone. And so say you want to get injection into your hip. Now I have the ability to do this in my office. So the plan is you come, we'll connect my device, my iPhone, to the actual ultrasound device. And I've never done this. We're going to see if we can kind of get it going online, that is. So here I am. I'm just opening up my sleeve here.
Oh, this is good, live.
That I will not ultrasound my hip.
Do you want me to inject you, or what's happening here? Do you have a needle ready?
Okay, so I don't know. You probably can't see it that well, but this is a live action of my wrist joint. So again, the image probably is not showing up that well, but I'll just give you an example. If you can kind of look at the screen and see something pulsating, that's the artery. In fact,
can you tilt your phone just down a little bit? Yeah, that's awesome.
Okay, so I've got it now on a color Doppler mode, and how's that?
Yeah, that looks good.
See some red stuff coming. Anyway, the gist is that This is an easy device now. And the beauty about this is now gives me the opportunity to use this device to localize the needle into the hip joint and then inject all sorts of things that we're going to talk about later on. But that includes cortisone, it includes the visco injections, which are like lubricants, and then even biologic injections. So it's, this is as new as they come. And it's a real great technology that can really change that gap of patients that maybe aren't ready yet for their surgery, but are still having significant pain and disability.
That's pretty cool stuff.
You want to unpin me there, Mike?
Yeah, I just did that.
Okay, great, thanks. So we're heading back to now we're moving from the non-surgical to surgical options with dealing with hip arthritis. And obviously this is a discussion that, you have with your own surgeon about whether you're ready for a hip operation. What does that involve? What are the risks, the benefits? What's the rehab? But just in terms of a high-level cursory talk about what the options are there out there for people that have severe hip arthritis, like our patient that we started the case with. So there's a standard hip replacement. There's a hip resurfacing. This can be done through a newer technique called the anterior approach, which I've been doing for over 4 years, and it's being done up at Southlake, and then all sorts of different type of bearing surfaces. So we're going to tie this, the hip to talk into our patient that we started with, our 52-year-old construction worker. So he was a young, active male, and he elected to go the hip resurfacing technique. And Mike, I'm going to get you to pin my video. Just want to show the,
sure.
In theory, what hip replacement surgery looks like. So
go for it. Sorry, Pat, you mentioned the direct anterior approach, and you're doing them. How many surgeons are doing them around the area? Because as far as I know, you're one of a few. Am I right?
Yeah, like certainly when I started, there was only probably a handful across the province that were using that technique. The technique itself, for those of you who are wondering, like, why doesn't everyone do it? Well, it's a technically harder operation. You often may need special equipment or a special table, and there's quite a bit of a learning curve. And like with any new technology, you get some early buy-in from surgeons, and then a lot of times it fades off. But I'll tell you, the audience out there tonight, this is here to stay. The number of surgeons that are performing this operation through the front is growing month by month. In fact, I've connected with the company to help train certain surgeons, and it's a real phenomenal operation. I've been operating for over a decade, put in thousands of hip replacements, and I've never seen people recover as fast as they do following anterior hip surgery. And I'm sure those therapists out there that deal with them also.
Yeah, 100%. It's way easier to rehab after it.
Yeah, I mean, the pain's less. You can do it as an outpatient. You minimize the soft tissue destruction, and there's also a lower risk of dislocation. But in terms of just what exactly hip replacement is, for those people that may not know much about it, is, again, we looked at the hip joint earlier. It's a ball and socket joint. And the idea is you've lost that shock absorber. So a hip replacement's got to replace that articular cartilage to some degree. So in this model here, you can see we've cut out the femoral head and removed the femoral, so we've cut the femoral neck and removed the femoral head, and we've replaced it with a stem, which is titanium, and subtype of femoral head, which is either ceramic or cobalt chrome. Then on the socket side, you can see the outer rim is a titanium socket, which gets implanted into the acetabulum. And then in that socket, there's actually a liner. And this liner is usually made out of some type of polyethylene or plastic. And this plastic clicks into place. And that's a standard hip replacement. It's inserted in an uncemented technique. It's a very reproducible operation. In fact, when you look at all the stuff doctors can give to patients in society, it's probably the most successful operation in terms of restoring quality of life. The next one being knee replacement, and the third one being cataract surgery. So anyhow, our patient did not get a standard hip replacement. He got something called a hip resurfacing, which is same idea with a hip replacement. In a sense, you're replacing the ball and the socket, but you're doing so in a different fashion. You can see on the x-ray here, it looks like we've saved all this bone. And in essence, that's exactly what we've done. And that's the concept behind hip resurfacing. You want to preserve bone for the younger patient. Unfortunately, it's only available for males, and there's reasons for that. But again, new exciting stuff coming to South Lake and to Canada is the idea of a ceramic on ceramic hip resurfacing. Currently, the only devices that we implant are metal on metal. This is the Birmingham hip resurfacing. It's been around for over 20 years. It's got excellent track record in the literature. But this whole concept of not taking out all this bone, but preserving it, I think is really important. And that's what our patient got, and he's quite happy. And you can see his post-operative x-rays right here. And he's
Hang on, I'm gonna unpin you back there, Pat, okay?
Thanks, Mike.
One of your patients, Beth, just commented in the chat that you did her anterior hip and it was amazing. So there you go.
Great.
Proof is in the pudding, right? There it is.
See, there's one happy patient out there.
Yeah. Good job.
So anyhow, you see on the x-rays here is you've got the cap and the socket, and it's ingrown well. And should this patient have trouble with this implant, which, maybe 15, 20, 25 years later, the nice thing about a resurfacing is that with all that extra bone, I can go in there and revise this resurfacing to a standard hip replacement, the one I just showed you. And so that kind of ends our talk about hip with last talk about the anterior hip, and we've already talked about this, but I just thought I give the audience out there an idea of what we're talking about with the anterior hip replacement.
Hey, Pat, a couple people, I think we should ask this question. We're asking why only males and not females. Can you give us a quick little, just
Sure.
a quick tidbit answer on that?
Yeah, so I'm going to go back to, that's a good question, and it's often like, why are the females getting discriminated with this implant? Well, metal on metal as a bearing surface in orthopedics has had a very tumultuous history. It was brought in about a decade ago. It thought the idea behind you could put a standard hip replacement with a big ball, which is metal, and a metal socket. And these were implanted in both males and females, but unfortunately, they ran into some major problems where they're all now been taken off the market. So you cannot get a big ball metal on metal hip replacement. There's many out there. Many of them, and most of them, in fact, are still performing quite well, but there was certainly some issue. And so when resurfacing came along, it was the same idea that this was a metal femoral component and a metal socket. This was also implanted in males and females. And then over time and through study, they realized a couple things with females. Unfortunately, as females get older because of osteoporosis that affects them disproportionately to men, is their bone gets softer. So on the x-ray here, as you can see, there was the higher incidence of femoral neck fracture in women. And that's just the nature of as women age, their hormones change differently than men. And as a result, their bone composition becomes weaker. The other thing is they found is if you couldn't implant a femoral head of a certain size, that you had issues with this weird metal on metal wear. And the other issue is these are being implanted in younger patients. And so the metal on metal prosthesis, and this is the case for resurfacing and metal on metal hip replacements, they generate metal debris. And that metal debris gets then absorbed into the blood system. And in fact, people with resurfacings often do have slightly elevated levels of cobalt and chromium, but there's really been no studies to date that have caused any concern with that. But the concern would be if you're implanting these in young women that may get pregnant, that what are the consequences of higher levels of cobalt and chromium on the fetus? And we really don't know. So resurfacing is less popular than it's been over the last 2 decades, but there's a growing interest, and the growing interest is this device here, the ceramic on ceramic resurfacing, because all those downsides to hip resurfacing I just talked about, whether it be metal on metal wear, inability to implant them in females because of the bone quality or the actual anatomic sizings, could potentially all be eradicated with this device. It's very early. There's probably only been a few implanted in the world, a few implanted in Canada, but it's coming and it's exciting. And it's just one of the other interesting things that kind of we're talking about tonight. Anyway, I hope that answered that question there.
Yep, perfect. Let's move on to the knee.
Well, just before we move on, I will just do one last touch about the anterior hip surgery, because it's very topical. People that are looking at getting hip replacement surgery, I'd strongly encourage you to get it done this way. There are more and more surgeons now trained appropriately in this technique. And just conceptually, why it's so good is you can see here on the diagram, this is like a cross section of the hip. So this is like taking a hip, slicing it horizontally. And this little section here is a cut through the pelvis. And so this is the socket. This is the femoral head. These are the little bumps. This is the trochanter in particular, we talked about way back when at the beginning of this. And then the red here is obviously the muscles, big nerve in the back of your leg, the sciatic nerve, and this is the femoral nerve with your femoral neurovascular structures here. So anyway, without boring you with all the hip and pelvis anatomy, this is arrow here is showing what a lateral approach. So the standard two most common reasons or ways you get your hip replacement done are through the side, which is the lateral approach. And you can see to get down to the hip from the side, you're cutting through these gluteus muscles. And those gluteus muscles are like gold. They're the most important structures of your hip. And if they get damaged or torn, you either permanently walk with a limp, you can develop some extra bony changes called heterotopic ossification in this side, or you can just end up with them tearing. It's a real problem. We do not want to violate those hip abductors. So the other way you can do is go through the back. You don't violate the hip abductors, but you take down these structures here, which are called your short external hip rotators and your capsule. And even though this is also a very good technique, it does come with an increased risk of dislocation. And you're also on your side when you implant these devices. And so, you worry about potential leg length discrepancies. So when you get your hip done through the front, the anterior way, you can see the blue line here. You navigate in between actual muscles and in between different nervous planes. And so as you can see, by the time you get down to the hip joint, you've taken down no tendons, you've destroyed no muscles, and you just open up the hip capsule. So, conceptually, as you can appreciate, this would allow for less pain and faster recovery.
Amazing.
So that really kind of ends the hip section. And so we're going to move on to the knee section, which, is the most common joint that suffers osteoarthritis in the world.
Can I just say one quick thing?
Yeah, of course, Mike.
So I know lots of people have some questions about the hip, and we're going to get to those in the question period at the end. One of our other physios here, Erin Albaum, she's keeping an eye on the chat and keeping an eye on the questions, everyone. So we're going to make sure we get to them all at the end. So we're just going to kind of keep moving. So carry on. You can go ahead, Pat.
Good. Thanks, Mike. Here we go to another patient of mine and a case study on the knee. So this lady, lovely lady, she's 67-year-old female. She's retired. She suffers type 2 diabetes. She still remains quite active in her retirement. She enjoys hiking. She enjoys pickleball, which interesting enough, I didn't know much about, but those people that deal with, musculoskeletal disease and people that are active, it's one of the fastest growing sport in North America. Anyway, so she comes to see me for left knee pain. And her knee pain's worse than the stairs. She also notes some swelling over the last 6 months, and she's tried some Tylenol and anti-inflammatories. And part of the reason I like this case is that it shows a different pattern of arthritis that you don't usually see. And it also, it highlights the importance of proper x-rays and the fact that you really only need x-rays. And so on this side, if the audience out there, when you look at x-ray, it's like the patient's looking at you. So this is her right knee. She's looking at us, looking at the screen. And this is her left knee. And when you look at them, they look kind of the same. This is her femur bone. This is her tibia. This is her fibula, which is a smaller bone in your leg. And you can see these are weight-bearing x-rays, which means she's putting weight through her knees. And you can see there's a gap between the inside part of her knee, which is what we call the medial compartment, and the outside part, which is called the lateral compartment. And her joint surface looks relatively smooth. And again, that gap, it's not air that lives there, it's the cartilage, it's the shock absorber. Now, when you look at the left knee, it's also similar. You can see a gap. You see these little bumps, those are little osteophytes. And the joint itself, when you just look at it from afar, you can see it's a little bit irregular, but there doesn't appear to be much severe arthritis in this patient's knee. But it's important when you get x-rays of the knee, you get all the views. And you can see with the special view here, is a tunnel view. And now when you look at her left knee, she's got severe bone-on-bone arthritis on the outside part of her knee. And I just, again, highlights the importance of good x-rays and proper x-rays. So her cartilage in that section of her knee is completely gone. So she's walking bone on bone, especially when she's going up and down stairs, which is why it hurts there. So what's her diagnosis? Well, we did a history, physical, we took some x-rays, and she's got severe left knee arthritis. So again, we look at some treatment options, and they can be broken down to both non-surgical and surgical options. And again, the focus tonight is that gap of patients that aren't ready for surgery. Maybe they don't have a severe disease, or maybe unfortunately their surgery is delayed because of wait times or COVID-19. What can we offer you? So, similar to the hip patient, we can talk about exercise, physiotherapy, bracing, and injections. I'm going to hand this over to Giacomo to talk about exercise and physiotherapy.
Great, thanks, Patrick. So I'm going to talk a little bit about a program in particular called GLAD, which help me out there. There we go. Okay, so I'm going to talk to you guys a little bit about the GLAD program, which is a program that was developed in Denmark a number of years ago, and so it stands for Good Life with Arthritis Denmark. Sorry, I'm just having some technical difficulties here. So we've run this program for a little bit in both Aurora and our Nobleton clinics with great success. I noticed in the participants that I saw some familiar names that have come through this program, and I can't say enough about it. We've had some really great success with educating people on the benefits of exercise. And so GLAD's an 8-week exercise and education program for individuals whose primary diagnosis is hip and knee OA. So they've gone in to see Dr. Gamble, and again, wait times are long and lengthy. And he says, have you tried some exercise? And most people say, yeah, I've tried a little bit of exercise. They've come through the clinic, and really exercise doesn't stick. I know Patrick's always saying, kind of what you put into it is what you get out of it with exercise. I hear him when he's doing some consults with patients, and this helps people stick with the program. It's 8 weeks of exercise and education. That's the other component that is really important. That the education component allows you to sit down with a GLAD trained therapist to discuss the ins and the outs of why exercise and lifestyle modification is beneficial for you as you wait for that knee, or in some cases, actually cancel your knee surgery or hip surgery. We've had a few patients that have just flat out canceled their surgery because they start to feel better. It's not the panacea. I'm not going to sit here and say that that's the panacea for your knee or hip arthritis, but it works. It allows you to ask questions directly to the therapist and understand the ins and the outs of the neuromuscular exercise program. So if anybody wants to type into the chat there who's done the program as to positives about it or some negatives, if you will, I'd be happy to see those comments. So as I discussed, there's 12 exercise sessions consisting of 60-minute group exercises twice a week. So there is a commitment to it. And then there's a couple of education sessions that are led by a certified instructor that, again, discusses the ins and the outs of exercise and lifestyle modification. So then there's a data collection portion. This is an evidence-based program. Again, I can't emphasize enough. It's not just something that we pulled out of the sky. This comes from a lot of years of research and implementation, particularly, started off again in Denmark and had some really good results. And we've been championing in Canada right now for a number of years. And the data collection portion of it is really important for quality monitoring and to understand how we can help improve the program. So bring on here, and so yeah, there's reflection on basically the person after they've seen Dr. Gamble, they come and see a therapist who then puts them through this program, and then they can carry on. And the idea is to develop good habits so that you can carry on this program after you've been discharged from it, and to continue on, hopefully not needing surgery or being stronger before you have surgery. And so, in our world, we kind of call it a prehab, if you will, We don't like to use this program as that, but it does work for patients who are looking to strengthen their muscles before they have surgery. And I won't belabor that. If anybody has any questions, you can certainly direct them to us at the clinic. Give us a call or email me after, and I'd be happy to answer some questions.
Okay, so Pat, if you want to go ahead and share your screen again, and we can get back into the presentation. So Giacomo, we do have a few questions about it. So maybe afterwards you can
Oh, okay.
I don't know, do you want to address any of those quickly right now?
I can address them very quickly. Kelly, unfortunately, it's not covered by OHIP. Some of the LINs, I know, which is the health networks within the province. I guess I don't know if they've been disbanded at this point, but the point is that some areas are covering it, particularly, unfortunately, in Toronto. But it's not covered by OHIP. So some insurance companies, in fact, most of them will cover the sessions because it's run by a registered physiotherapist. So we can discuss that in a little more detail, but generally OHIP does not cover it. It is privately funded, but insurance companies will actually fund that program. So you can recoup some of the money, if not all of it, that you.
Yeah. Awesome. All right, let's move on.
Yeah, that's good. Thanks, Jack. Mike and Giacomo, as many of the physiotherapists in the clinic, have heard a lot of my one-liners. And I must say, when it comes to exercise and physio, I always tell my patients, what you put into it is what you get out of it. And it's like brushing your teeth. You got to do it every day. So I think those are two good things to take away from that as well.
Mm-hmm.
So another non-surgical option would be custom OA bracing. We touched upon that with the hip. There's not a lot of options out there. We're fortunate that there is actually an option now, a dynamic option. And I'm going to turn this to Mike to chat about what's out there for OA custom bracing in the knee.
Yeah, so as you can see on the screen here, there's three big companies that sort of deal with a lot of the OA bracing. Oser, Bragg, and Donjoy, and all these companies offer a custom brace, an offloading brace that's meant to help biomechanically correct the knee position to offload how much pressure is on it when we're using our legs, walking around, doing things. They each have their own specific benefits, and we sort of deal with all three companies and try to get patients into the right brace meeting their exact needs. So that's why we have a few options here. Pat, if you want to go ahead and screen there. So the idea of custom braces is it's meant to reduce your pain, allow you to perform more activities similar to the hip brace, and they do this in a biomechanical nature. I have a couple examples here. Again, there are versions of a two-hinge brace. This is the Bragg Duo. And basically how these work is as our knee straightens, which is where we're going to get most of our joint compression, bone on bone happens in that extension position as we're walking often. As the leg straightens, a lot of these braces shift the body weight. So they, in essence, I'll use my hands as a simple strategy here. As your knee is straightening up, you're going to get a little bit of a shift to help offload the joint. And that happens through a lot of these braces. This one here is the Oser Unloader 1, okay? Same type of thing. There's dials to help correct, and this uses more of a pulling action to help alter the position again of the knee in these positions. So these are dynamic, so they work at certain angles where we find the greatest problems with arthritis. Donjoy also has a version. Again, these are all different models that also help with these offloading features. Again, we sort of look at what is the patient's needs, what kind of brace do they need, what kind of activities are they in, how much mobility, etc. Maybe they need a lot of offloading, a little bit. It depends on the severity of their condition. Similar to the unloader hip, a lot of the custom bracing is covered by insurance. And most companies, most insurance providers do cover the cost for these, and along with a prescription for the doctor and information that they require, they often get covered. These are custom products, so if you have one made for your right knee, you can't put it on your left knee because there are certain dimensions and angles obviously at play here to affect that one joint surface. So they're not usable on both sides. As mentioned, custom means we measure your leg and they build the brace exactly to your dimensions, and we'll work with the patients to make sure they're as comfortable as possible. Some of the other options here mentioned in this slide, we talked about the knee braces. There are some features, some knee sleeves out there. They're proprioceptive effect only, so they give you that sense of control, comfort, that you have some support around your knee. Some orthotics are also an option out there for biomechanical changes, but the biggest one are these custom braces, which can really alter the position of the femur and tibia to offload those areas of the knee. I know a few people here have on the talk tonight have one of these and enjoy it, and it really gets you moving again. It gets you functioning. I tell patients, if it's going to take you a year to get your knee replaced, what are you going to do in the meantime? Are you going to live in pain every day, or can you at least use one of these products or an injection to get you through and stay active, and it's quality of life that ends up improving in the meantime. So there are many options out there that we just wanted to show people instead of just medication and waiting and suffering and pain.
So Mike,
yeah,
I'm going to ask you a couple questions because, you know, like, I don't know as much about bracing as you and Giacomo. So we'll turn this back to this patient. What about her? Is she a bracing candidate? Because my understanding is not everyone's a bracing candidate.
Yeah, so she would be. What we call in this scenario is a uni-compartment arthritis. So as you mentioned, her lateral component or her lateral joint surface is affected. So if we're going to shift the bones outwards to offload the outer part of the joint with one of these braces, we won't do that by disrupting the inner portion of the knee. If this person had multi-compartment knee arthritis, these braces are not recommended because they're going to end up creating pain in another section of the knee. So it's usually these uni-compartment categories of patients who get the greatest benefits from these.
That's great. Yeah, I would agree. I think someone like her would be a fantastic candidate for a custom brace.
Yeah.
You know, when you look at patterns of arthritis, the most common pattern arthritis is affected on the inside part of the knee, which is the medial compartment. They're also good candidates for bracing. They often got legs that look like John Wayne, so they're bow-legged. The lateral compartment arthritis, which is our case today, they're also excellent. And then the third most common pattern of arthritis, which accounts for less than 5%, is kneecap arthritis or isolated kneecap arthritis. And they really are not good candidates for bracing. And that's why it's so important to get a healthcare professional to make a good diagnosis to what type of arthritis you have. If you've got severe tricompartmental arthritis, so all parts of your knee are severely arthritic, meaning you have no cartilage in all three parts of your knee, custom bracing is not for you, as Mike elucidated earlier. So then you've looked at, we're kind of going up the ladder in terms of other non-surgical options, and we're going to chat about knee injections. It's I appreciate it's 8 to 20, and this is about an hour webinar. I'll stress it.
But we might go a little over time here just to get to some questions, but I'm sure most people are still engaged here, so I think we're pretty good.
Absolutely. I'm not going anywhere.
Okay.
Mike hasn't turned on the air conditioning in the clinic. I'm getting a little hot in my office, but
once the questions come, you're going to get a little bit hotter under the collar as well, so don't worry.
So anyhow, knee injections, it's a great topic. There's lots of them on the market, and hopefully I'm going to educate the audience out there about what are the pros and cons and whether one of these injections may be good for you in your knee or maybe even your hip now that we have ultrasound guidance. So the most common one, the one that's been around the longest, is cortisone. And, I've heard all sorts of things about cortisone, and there's lots of misconceptions out in the general public about cortisone injections. People often come and say, well, I'm worried about cortisone. It's going to damage my joint, or I can only have 3 in a lifetime, or, cortisone, it's the only injection that I can do in my knee joint. And unfortunately, all those are false, or fortunately, I guess. The reality is cortisone is a natural hormone that regulates all sorts of different biologic interfaces in your body. It's a steroid, which is its chemical compound. And what it is, it's a very powerful anti-inflammatory. And there's lots of different types of steroids out there. And when you use the word steroid, sometimes it has a negative connotation, like anabolic steroids, which clearly are probably not good for people's health. There's other types of steroids like prednisone, which are used to treat various inflammatory or chronic diseases, which does have systemic side effects. And so someone like our patient here who's got a history of type 2 diabetes, a systemic steroid like prednisone would need to be exercised and used with caution. But when you talk about cortisone, you're talking about intra-articular injection. And intra-articular injection stays just there. It stays in the joint. It's a local treatment. So there's little to no systemic absorption of cortisone in the body, which means it doesn't really matter if you are on steroids, if you've had steroids, if you have other diseases like diabetes in which steroids do aggravate your sugars. Cortisone's safe. It's well proven. It's a very powerful anti-inflammatory. It does not cause joint destruction, and you can use as many as you feel necessary. It usually gives people relief 2 to 3 months. I am happy to repeat them as much as the patient wishes, but eventually at a point, its effectiveness decreases, and then you move on to other potential options like the visco injections, which is a second type of knee injections. And when I think of that, and when I explain it to patients about the types of injections on the market, I like to think of it, break it into 3 categories. One is the anti-inflammatory, which is the cortisone injection. The second is the mechanical injection that we have. So the visco is a broad category of lubricants or gels that you inject into the knee. And all of them have the similar concept in a sense that they've created synthetically this big macromolecule. And I've showed it here. This is the chemical compound. This is the 3D diagram. And that's hyaluronic acid. It's like the big shock absorber that we talked about. It's the main molecule that makes up the extracellular matrix of the cartilage layer. And unfortunately in arthritis, there isn't as much there in the articular cartilage or the fluid in this synovial joint, and it's broken down. So the idea behind all these viscos is that we can replace some of this shock absorber mechanically into your weight-bearing joint. And it works great. These work for a lot of patients. They don't work for everybody. You never know till you try. There's lots of them on the market, and the 2 I show up here are the 2 that I use. And the reason I use them are for a couple reasons. Is when you look at viscos, it's not just a class effect. In the literature, you want to look at viscos that have high molecular weight, so they're bigger molecules, and that there's some cross-linking. So they're made in a way that the compound basically resists mechanical stress better than some of the other ones. So there are cheaper ones in the market. The ones I inject are these single injections that are high molecular weight, have cross-linked. Durolane is a little bit smaller volume. I tend to use these in the hips. The Synvisc is a little bit bigger volume, but still very little. They're 3 cc's and 6 cc's respectively. They're very good. The people often that get relief from anywhere between 4 to 6 months. The only side effect of these, because again, you're injecting a synthetic natural molecule in your knee, is just the cost and potentially some local injection from the needle going in. And then that brings me to the last category of injectables, which are the biologic injections. And, I'm going to look at the end of my slide here to start. And it's important to realize that this is not PRP. This is not stem cell injections. So if you remember way back when, from an hour ago, we introduced this talk trying to understand what arthritis is, and that it's a biologic disease. We're understanding it better as more science is being performed. but the nuances of it, we do not understand. When you look at other types of arthritis, like inflammatory arthritis and rheumatoid arthritis being the most common type of that, that's also a biologic disease where your body is attacking your joints. The treatment for that is biologic treatments. In fact, to a point now where I rarely see a patient that needs a hip or knee replacement as a result of long-standing rheumatoid arthritis. And the reason for that is the biologic treatments are so good. Osteoarthritis is also a biologic problem, but we do not understand it as a medical community as well as we understand rheumatoid arthritis, but we're beginning to. And this is why it's so exciting, because now we have the ability to inject in second generation biologic injections. PRP is an injection where you take the patient's blood, you spin it down, and you get that platelet-rich plasma. So a portion of the blood. And the concept of PRP was, can we create an environment in which we can repair the damages? And it was studied in all sorts of problems. It was studied in various tendon problems, in hair loss. Clearly, I did not have PRP. But the issue with PRP, when you look at the literature, is its indications are so broad. And when you actually tease it down to PRP in osteoarthritis, there's very little to no data to suggest that this works. And there's different types of PRP, and that statement can be true for both types, both leukocyte-rich and leukocyte-poor. The idea behind stem cell treatments is that you can harvest out some stem cells, which are early cells that haven't totally basically specialized in their function. And then is there some way we can inject them into a diseased joint and allow them to recreate the articular cartilage? And currently in Canada, you cannot do treatments for osteoarthritis. So those types of injections, which what I would consider first generation biologic injections, I personally have had very little clinical experience. When I look at the data and literature, it's been poor at best, which is why I decided not to go down this road. They're out there, doctors are injecting them, and I am not being critical of that. Just my personal opinion, when you look at the literature, that they just aren't terribly effective, and they are costly, because the issue with all these injections is these are not covered by OHIP. They come at a significant cost. The cost is often proportionate to its effect. So when you look at cortisone, it lasts 2 to 3 months. Viscos may last 4 to 6 months. And when you look at this second generation biologic injection, N-Stride, when you look at the literature, I'll quote my patients that you expect 75% of them to see some significant improvement, and this improvement lasts anywhere between 1 to 2 years. The idea behind this injection is we take your blood, we spin it down through 2 cycles. So you go through the centrifuge twice, and what that does, it selects out these specific proteins, are anti-inflammatory proteins. So they combat those inflammatory proteins. And when you look at the makeup of an arthritic joint, it's this teeter-totter scale and balance between proteins and cytokines and inflammatory mediators that want to break down the cartilage and those that want to build it up. So the idea behind is, can we block the effect of those proteins that are trying to break down this joint and possibly slow or reduce the progression of arthritis? It's important to note that this injection does not repair it, but the science looks at slowing it or possibly reducing it. And to me, that is really getting at the heart of what osteoarthritis is. Maybe it's not so much a wear and tear phenomena, it's a biologic process that potentially we can intervene and change. And I've been doing them recently as it's a very new injection, and to date I've been pretty happy. And now I'm hoping to open this up to those patients, those gap patients, those patients with mild to moderate disease, or those patients that are waiting for a joint replacement and the wait's a little long.
Hey, Pat, how long has N-Stride been around for?
It's gone through various stages of development. It's probably about 5 or 6 years in terms of research design and then early clinical trials. It was studied mostly in Europe initially, bought up by a recent company, Zimmer Biomet now, and it's kind of more openly accessible now. But it's very new. I would say, there's only a handful of surgeons and doctors that are performing this. And we certainly are at ASMP and Nobleton Physio, and have been only since this year. So, and now with the advent of handheld ultrasound, the chance that this may be injected into hips is also I think gives a lot of hope for patients out there that are suffering, that, as I said earlier, aren't ready for a joint replacement, or just waiting for their joint replacements. Because Directive 2 today has been modified by the government, so elective operations are being allowed as of tomorrow. But the reality is this ramp-up phase is going to be very slow. There's going to be lots of new checks that need to happen for patients that come in for scheduled surgery. We're going to have to still maintain the capacity in case there's more surge COVID patients. So the next 6 months when it comes to scheduled surgery is going to be a real challenge, especially for orthopedic patients. So these options that we're talking about tonight, I think, fit really nicely and are very timely to the situation. So anyhow, let's go back to our patient. So she's got some end-stage knee arthritis. She's gone through the ladder of different non-surgical options. And then finally, what else is there left for her? Well, surgery. And the beauty thing about surgery is that, while we've been talking about managing symptoms and delaying possible surgery, the beauty about hip and knee replacement, one, it's one of the most successful reproducible operations medicine can give people, but it's a cure. We cut out the arthritis and replace it with something metal and plastic. Now, there's a few people that are out there that have had joint replacement surgeries, and hopefully most of them are really happy, but it's not what God gave you. They're metal and plastic. I don't pretend to say that every patient that gets a joint replacement is perfect. There is a subsection of people that get knee replacements that are happy, but maybe not as happy as they wish they were. The knee joint is a complex joint that probably is not totally understood from an implant and surgeon perspective. But the good news is that hip and knee replacement cures your disease, and it's very reproducible. So then many people out there may be wondering, when surgery right for me? Well, as I said earlier, arthritis ain't going to kill you. It's a quality of life operation. Yeah, you're looking at how bad your pain is, what type of disability you are, and when you've tried these non-surgical treatments and they're not working anymore. And the three questions that I find the most relevant is on a scale of 1 to 10, 10 being your worst pain. If your pain is an 8, a 9, or a 10, that's significant. If you've tried all these other non-surgical stuff and you just feel so distraught that you're thinking about taking narcotics, that's significant. I would strongly counsel you never to use narcotics for arthritic pain, but some people certainly feel that's the only way to get some relief. And then lastly, if you can't sleep at night because of your pain, that is also significant. So patients that often come time for hip and knee replacement, they may have 2 or 3 out of those questions positive. And that, for me as a surgeon, is a good barometer to see if their symptoms justify a big operation like a joint replacement. Now, when it comes to a knee replacement, there's lots of different stuff on the market and lots of different operations. And this is a good discussion you have with your surgeon. You can see on the screen to the left, we've got examples of partial knee replacements. We've got a kneecap replacement here. We've got a medial compartment, half of a knee here. You've got a total knee replacement here where both the femur and the tibia are replaced with a plastic in between. And then when you look above it, we've got an arthroscopic picture of a knee. And this is what the knee joint looks like when you look at it through a camera. You can see here, this is the articular cartilage, that shock absorber. There's little flaps here. That's what arthritis looks like, actually, when you look in the scope. This is the meniscus. And you can see there's tearing here. And then this is the tibia. And the reason I include that picture tonight is, a lot of people do come to me with knee arthritis and they wonder about the usefulness of arthroscopic surgery. And the reality is, if you've got moderate to severe knee arthritis or any type of hip arthritis, arthroscopic treatment is not a very reproducible operation. So unless you have traumatic pathology like a meniscal tear and you've got very little knee arthritis, I would discourage people from entertaining the use of a cleanup or debridement procedure. People do see relief. It's often short-lived, and 6 months later, they end up being back to where they were before, and they have exposed themselves to an operation, albeit a low-risk operation. And again, these are the discussions you have with your doctor and surgeon in particular. And so that leads to my last point, my best tip. I'm sure you've all been anxiously awaiting this at home with bated breath, and I'm sure most of you just haven't decided to tune off this webinar because of dying to hear about my best tip. And unfortunately, I hate to disappoint those people in the audience, but it is not mind-blowing. nor revolutionary, but it is real. And my best tip is weight loss and staying active. These two things kind of go hand in hand because, well, they're related. When you are active, you lose weight. And unfortunately, when you're inactive, you gain weight. Gaining weight in arthritic joint is significant because for every pound you gain, it's equivalent to 4 pounds in your knee. Now, I'm always a glass half full type of guy, which basically means if you lose a pound, it's equivalent to 4 pounds. Every step you take, there's 4 times the amount of force goes through your knee joint. So if you think you can lose 10 pounds, which doesn't seem like a whole bunch, that's 40 pounds of weight through that joint. And when you look at it over a mile, that's nearly 50,000 pounds. So I would encourage the audience tonight is, activity does not cause further wear and tear, does not cause further damage of your arthritic joint. And even a little bit of weight loss can make a big difference.
Perfect.
I'm going to go back to Mike, and and then he's going to chat to you about the last few things.
Yeah, so we're going to get to the questions here in a second, but I know a lot of people have further, they want some further information. So what we're going to do tonight is offer 3 choices for some people if they're interested. One, a free kind of home exercise cheat sheet, we'll call it, some top exercises Giacomo will offer us you can start doing now for your hip or knee arthritis. The second option, if you want some more information about the bracing, what it is, how it works, learn about that, that's another option. Third one, we're doing some virtual stuff here. So we're doing some no charge video sessions. We can discuss your issues further, perhaps, if you wanted to kind of ask a few more questions to myself or Giacomo. Dr. Gamble's a busy guy, helping everyone out at the hospital. So we can answer some rehab related questions and bracing, et cetera, for you. So if you want any of this stuff, just let us know, type into the chat, exercise or bracing or video or all, and Giacomo and I will personally reach out to you. And furthermore, to the questions right now that we're going to get into, we're going to get into as many as we can, guys. We're in overtime right now. Who doesn't like overtime? It's the most exciting time. But if we don't answer your questions, we will reach out to you and help out, okay? And we will call you and try to get all the answers we can for you guys. So I love everyone's throwing what they want in there. That's awesome. So Aaron, can we start with a few of the questions? Then again, everybody, let's see if we can kind of hammer out a few and go from there.
Yeah, definitely. I'm going to try to start with the questions that were coming up a lot. And one that was coming up a lot where people were asking, how long does a hip or a knee replacement typically last?
Thanks, Aaron. That's a great question. And in my rambling, I seem to have forgotten that point because it's a common question that patients ask for me, and it's relevant. So the simple answer is probably most of your life. When you look at the literature, modern hip and knee designs with the new plastic last 20 to 25 years plus. In fact, part of the change in hip and knee replacement now is we see people getting hip and knee replacements younger and younger. The fastest growing decade that gets hip and knee replacements are people in their 50s. 20 years ago, when I was in my residency, you wouldn't operate on a patient that was under 65. But now, because of technology and because people want that quality of life now, and rightly so, age is rarely a deterrent to surgery, and they last a really long time.
Awesome. Thanks, Pat. Another question here from Jim. He's asking about activities following surgery, and that would be for either a total hip or knee replacement or the hip resurfacing procedure that you were talking about, and if there's any limitations.
So another great question. Thanks, Jim, for tuning in. Appreciate that. So the standard answer would be high impact activity. Most orthopedic surgeons do not recommend. And the one main activity would be running. Now, for my hip resurfacing patients, I let them do whatever they want, including high impact running activities. In fact, you look at the athletic world, and in particular, most recently, Andy Murray, he had a severely arthritic hip. He ended up with a hip resurfacing, did return back to competitive singles tennis, and ended up winning a big Masters event. So I say to all my patients, hip and knee patients, do whatever you want, because I'm a strong believer that your doctor should not be limiting your activity. Being active is one of the most important things. And when you looked at older technology, and in particular the plastic we used to implant in hip and knees, it wasn't very good for lots of reasons I won't get into. But now modern technology and modern plastic is so good that high impact activities, albeit are not strongly encouraged by surgeons. For myself personally, for other reasons, I encourage people to do as much as they possibly can.
Awesome, thanks. There was also quite a bit of interest about N-Stride. A couple of the main things that came up were people were wondering if it can be used in hips. And they're also wondering, you talked a lot about how the injection slows down the degeneration, but they were wondering if it offers relief.
Yeah, another great question. So the N-Stride was studied solely in knee arthritis. And that's important for a few things. As you look at the other biologic injectables on the market, they made the injectable and then they went looking for a solution that it could possibly solve. So in this case, they tried to understand the disease first and then create and find proteins that were going to treat the disease. So this injection is only for osteoarthritis. It was only studied in knee osteoarthritis just because it's so prevalent, it's easy to inject. However, it can be injected in other synovial joints with osteoarthritis, and that includes the hip. So N-Stride is definitely indicated for hip arthritis. Ideally, it's moderate disease, but it can be injected for advanced disease. The idea behind it is that it's slowing the progression of the inflammation and cartilage degeneration, which then gives patients symptomatic relief. In fact, the studies that were done compared this injection to the other injections we talked about, which were cortisone injections and visco, because there's no point bringing a biologic injection to the market to patients if it wasn't better than what was already there. So when you looked at the N-Stride injection, it was better than the viscos and it was better than the cortisone, providing patients relief and improvement in function.
I'm going to just chime in for a quick second. There's been a few people asking if they can watch this session again or send it to someone. And yes, everyone, I just put into the chat here, we're recording the webinar tonight and it'll be available to watch in a few days. We'll get it posted at www.aurorasportsmed.ca/webinar. So you can direct any of your friends or family, they can watch the session. You can listen in again. Maybe you missed something that Dr. Gamble talked about, etc. So I just wanted to throw that in there.
Just one thing too, up on that N-Stride injection, because Mike and Giacomo mentioned how you can connect with them. Connecting with me is a little harder just because of the rules on how a consultant sees patients. But if you're interested in an injection, whether it be a visco or cortisone or N-Stride, what I encourage people to is connect with their family doctor and send a referral, and then specifically say, interested in injection. And then I triage all of my referrals. And, given that I'm not operating a whole bunch right now, I do have time to see people and talk about injections and perform these for them if they need.
Awesome. Thanks, Pat. Can you also just speak to the cost of N-Stride and any coverage that's available?
Yeah, in fact, I'll speak to the cost of all the injections because it's another important point. So the cortisone is $50 through my office. The viscos are $550. All of them come with tax added on top of that. And then the N-Stride is $2,200. So you can see there is a significant cost, like the bracing we talked about earlier is, unfortunately, these are not covered by OHIP. Insurance plans, most of them will cover the viscos. Most of them will cover the cortisone injections. N-Stride, because it's so new, is not covered. It's price equivalent to the PRP. PRP is usually injected over 3 times. And when you look at the costs for PRP injections over 3 sessions, it's equivalent to the N-Stride, which is injected in 1 session.
Perfect. And then we have Brian wondering how your flying is going and if you've gotten your license.
You know what? Thanks, Brian, for asking that. I'm very close. I've soloed. I've done my cross country, and now just before COVID-19, I was had my flight test booked, but unfortunately, I'm a little rusty. So maybe he'll be happy to take me up and teach me a few things.
Perfect. Okay, Pat, I'll give you a little break. Mike, maybe a question for you. Some people are just wondering about fittings for braces during COVID.
Yeah, so now, I mean, a lot of the restrictions have been lifted for us, so we are able to see patients directly here at the office. And, you know, we're using our PPE appropriately here, and we're able to do the measurements and fittings with people safely. So for those, again, that are interested, you know, certainly let us know, and we can help that out. That's not a problem.
Perfect. And question for you, Giacomo, about GLAD. I have a couple here for you.
Sure.
People are also wondering if this program is running right now with COVID.
Well, right now we can't just because of the groups. So we typically run it in groups. We can do it one-on-one or in small groups, but that would, you know, push us beyond, you know, being safe. So we're going to try to pilot possibly doing it virtually. And some clinics have been doing it. In fact, Toronto Rehab has been, I think, talking about it. And so I think we're going to try to do it virtually. If we can get a critical mass of people, we will certainly do that virtually. So stay tuned.
Awesome. And as well, can you just comment on the cost? And people are wondering if this is also appropriate for people that have had a knee replacement already.
Yeah. So so it's $500 for the sessions. Now, if you divide that by 14 sessions, so it's 12 active sessions and two education sessions, we issue a receipt for those sessions. So it's divided by 14. I'm not going to do quick math here, guys. So whatever that works out to be, but I'll tell you, it's a great program. And sorry, Aaron, the second half of that question after cost
was that if people who have had knee replacements would be eligible.
They would be if they have, you know, if the other knee or hip is affected. If we typically it's the primary diagnosis is the hip or knee arthritis. So if they've had an arthroplasty, then the answer would be no. We could do some of the exercises individually. We could certainly give you those exercises individually. So yeah, contact me and we can discuss that. I've done one-on-one sessions with people using those exercises. It's not exclusive to, you know, an individual. So I can talk to you individually about that another time.
Perfect. Pat, this is a question for you. People wondering about supplements such as glucosamine, collagen, or medical cannabis or CBD oil, if you can comment on any of those.
Yeah, sure. Thanks, Aaron. So those could be lumped under, we'll say, nutraceuticals, which would be nutritional supplements. And if you remember back to the talk about the viscosupplement, that big macromolecule, which is hyaluronic acid, is the building blocks for that is glucosamine and chondroitin. So the shark's cartilage or the Lakota, which you've seen, there's very, very soft evidence that maybe if you increase the nutritional load that you intake, that could potentially increase the production of hyaluronic acid. But when you look at the literature for that, it's not very convincing. So I personally don't recommend it. I have very limited experience prescribing CBD. But I do hear lots of patients use it and feel it makes a difference in their lives. So, you know, I think that's it's really for patients, for them to decide what type of nutrition they want to take for themselves.
Hey, Pat, I got a quick question. Just to clarify, cortisone's not covered by OHIP, is it?
So the fee to inject it is covered. So the patient can come see me. They don't get charged a visit. I charge for the actual product. Some surgeons may give a prescription to patients, which they subsequently will go pick up from the pharmacy and then bring to the injector. And I just for convenience sake for the patient, because I'm so busy that if you want it, it's here. I'm just passing that cost that I do to purchase the cortisone onto the patient. Now, viscos are a little different. It actually is a delisted service. So if you want to inject the visco by most doctors, it's actually not covered by OHIP. Now, I just absorb that cost myself. I don't charge the patient for the actual injection or the use of the ultrasound to inject it if I use that, but they pay for the cost of the product. And so that's just kind of how I do it. Most patients are happy with that because insurers tend not to cover the cost of a physician service, but they will cover the cost of a product like the viscos.
And you mentioned this earlier, but if people are interested in these injections further, and you know it's hard to get in to see you, you mentioned something about triaging. Can you repeat that again?
Sure. So I triage all my referrals.
Okay.
So I do need a referral to see patients from a primary care or another specialist. I can't unfortunately do walk-ins.
Yeah.
But if you're interested, most doctors are happy to send them my way. I just need a fax to my office, and I triage them. And if it's simply for a cortisone, visco, or an N-stride injection, I can see it quickly, especially in this time because, as I said earlier, no scheduled surgery, so I'm available.
So those docs who are referring their patient should indicate, discuss injections, please, with this patient. And this way you're able to kind of pick that up and be able to triage it, correct?
Yeah, that's correct, Mike. I mean, you'll find, I'm sure everyone's got different experiences with all sorts of different doctors, both specialists and non. Sometimes you need to encourage a doctor that this is something you may like or you feel you may benefit from. I've gone out and I've certainly done lots of talks to primary care doctors about other non-surgical options because, you know, even part of tonight is I mean, the main thing tonight is educating the public about there's more out there than operation or just living with your pain. There's all these other non-surgical options that have good science, good evidence that can help you enjoy an active, pain-free lifestyle.
Okay, yeah, because I know a bunch of people have been saying on the chat here, like they've had the referral sent in, but they're now maybe a bit more keen on these injections. So if those folks are interested, certainly reach out. You can just put your name in the chat here, or just put you're interested in injections, type it in, and then we'll flag it and contact them and go from there. But I think that'll help. I just think people are sort of there realizing, gosh, it could take me 2 years to see Dr. Gamble, but maybe one of these injections could help me right now, right? So
yeah, exactly. So, you know, I have had long wait lists personally for a while, but that's been more or less corrected over the last probably 9 months or so. I still have a bit of a wait, but, you know, if the referral is for a hip or knee replacement, whether I see you next week or 6 months, it's not going to change your total time from that time of referral to the time you get your hip or knee replacement. Unfortunately, the bottleneck now is way down the line, and it's going to be in terms of access to the ORs. But if the referral is, hey, I would like an injection, that's easy. I can see people relatively quickly, and we can plan these injections easily. Okay,
perfect. Aaron, any other? I know we've touched on some questions. I've had a couple as well, Pat. Just some people who have asked about, you know, after knee replacement, the knee makes a little bit of clicking noise. That's probably just more mechanical sound from the surfaces, the new surfaces, correct?
Yeah, Mike, that's another common complaint I hear from patients. In terms of people that have had knee replacements out there, you know, I mentioned it earlier, there is a section of, you know, maybe 15-20% of patients that get knee replacements that I would say are not super happy. You know, less than 5% suffer a major complication, and of that 5%, most of those patients can be treated well, but sometimes it requires further revision surgery.
Okay.
So there's a section of patients that have continued symptoms, and they may be pain, they may be swelling, they're often maybe mechanical. It is a mechanical device. Again, it's not what God gave you. It clicks, it clunks. There's often some numbness on the outside of the knee. Those tend to get better with time, even though the recovery following a knee replacement is very fast to a point where you go home nearly the same day. You're walking, you're bending without any restrictions. It still takes a whole year to a year and a half to fully recuperate. And I try to educate my patients preoperative that, yeah, you will see some major improvement in your symptoms early on, especially if you link in with a therapist and do your rehab. But it's a long grind to get that last 10, 20%. And even after a year and a half, it may not still be perfect. And that's unfortunately a bit of the conundrum with knee replacement surgery, especially when you compare it to hip replacement patients, which, you're looking at 98% of patients are just thrilled with that operation.
Right. Aaron, any other sort of summarized questions there that we can get to? And we'll wrap up here in the next couple minutes. I know some of the attendees have left the session now. We should get wrapping up here pretty soon. Any last simple questions? And just to kind of throw it out there again, folks, if we haven't answered your questions, we'll do our very best to look in the chat and reach out and connect with you to hopefully provide some information for you. But that's great. Sorry, go ahead, Aaron.
For sure. There's obviously tons of questions, and I'm just trying to pick the ones that apply to everyone just to get the most information out to the most amount of people. There's been a few comments about people having like swelling in their knees and wondering if anyone can comment about like ways to manage their swelling.
All right. There are different compression garments you can get for your knee to sort of assist with the swelling. Depending if it's an active, acute swelling, whether icing is required. Generally speaking, it's probably trying to modify a bit of activity, work on some strengthening, reduce the load on the knee. Hopefully the effect of the swelling is mitigated. That's what I would say from a physio side. Would you agree, Giacomo?
Yep, definitely. And then of course, if it's in the chronic stages, that's something that, even exercise can help, right? As far as managing some of the swelling.
Awesome. Yeah, I think a lot of the other questions here are pretty individualized. Depends if you guys want to keep going.
I think I see got quite a few people dropping off here. Maybe time to just wrap it up and.
Yeah, so listen, everybody, thank you so much for attending tonight. This has been an amazing session. We do plan on doing more of these types of sessions, and I think Dr. Gamble will definitely grace our presence again with more interesting topics down the line, but it's been great. So, Pat, thank you so much. I know a lot of patients and the members of the public out there are happy to have joined this tonight and listen, at least get a little bit of more information. And don't forget, folks, if you typed in bracing or exercise or video, we will get to those and we will get in touch with you and make sure you get the information that you were asking for. So Giacomo, thank you again for the GLAD stuff. And Dr. Gamble, once again, thanks so much. That was really great. Thanks everybody. And Aaron, thank you for helping out. So awesome. Everyone have a great evening and we'll see you soon. Take care. Next week we reopen. All right, we'll see you guys. Take it easy.
Night.